Good morning. So I had the pleasure of giving you the dramatic talk about how we're going to save you with the CT. These are my disclosures. To make it quite clear, we're actually not going to save you today. We're going to actually decide if you really want to use CT or not. And we're going to cover the CT LAA protocol, how difficult or how simple it actually is, and really define if you think you need it or not. And you might not need it. And then discuss the goals of intracardiac echo, ICE, because it's coming and it's here to stay. We always want to talk about dollars and cents because as clinicians, we don't understand that. And we don't think about the patients in the hospital. For a patient, they don't want to have 2 visits. They don't want to do a TEE and wait 6 weeks or wait 6 weeks for coming in. For a CT, they can have 1 visit to the hospital, 1 transportation, no sedation, no driver needed, and they're done in 3 minutes or less. For a hospital, you can actually bill for it because the pulmonary vein CT is already used by our electrophysiology colleagues, and they already bill it for cardio mapping for AFib ablation. A happy patient is also more likely to schedule a procedure within a 24-hour turnaround, and everybody wants Amazon Prime nowadays. They don't want to wait a few weeks for a procedure and say, I didn't bleed, so I don't need a TEE, I don't need an LAA closure. So there's no delay in care. But do you really need to go beyond TEE, and do you really need a CT? The really easy answer is no, you don't need CT. Unless you're Dr. Huber, because he does any kind of LAAs. He does the complex ones, the ugly ones. He doesn't just do the pretty ones. And if you want to do a practice that's only the easy LAAs, you don't need CTs, because this is what the Watchman looks like on YouTube. And everybody can put a Watchman device into this appendage because it's very easy. A 21 device, doesn't matter how deep or how proximal you put it, you'll get it in there. But when it has an acute angulation, it becomes a little bit more difficult, and you might not be able to sock it in because you need a little bit more torque on your catheter. And when you get to medium, you might not want to use it. And what about the hard ones? When you 3D print, you have 2 different lobes. 2 different lobes, we saw the complex ones that were shown early in the excellent talk. You can do double Watchman devices or an AVP or ADO2, but if you're not comfortable, that's a patient we're going to pass on. So what do you want to do, and what kind of practice do you want to have? Operator discomfort is real, and as an imager, it's really, really easy for me to say that, but for the implanter, it's very, very challenging because our devices and our catheters are very limited in ability to torque at these days. A lot of people don't like the 33 device. Why? Because it pops out, and when it pops out, you lose your curvature. So you try to stick it back in, it looks even more ugly, and then you have a failure and an aborted case on the table. And when you have an angulation that's also big and wide, and you can't get into anterior curve, you're more likely to not do the case too. So why shouldn't you do CT? I've put a list of excuses on here that I've heard that I actually see implanters use, and I see imagers use all the time too. And I don't have an answer for you, but if you don't have enough lab space to handle more cases, you actually should not be doing CT because you have more cases to do with CT. If you don't believe in LAO therapy and prefer anticoagulation, I can't help you there either. If you don't want to do 6 to 8 LAA procedures per day, can't change your mind on that. If your hospital administrators don't want to purchase more devices for shelf space and you don't have enough shelf space for all the devices you need for 8 procedures in a day, we can't help you there either. If you don't want to touch a 33 device, or if you just absolutely love your double curve, we really can't help you there either. If you don't want to scale an LAA protocol or LAA program, you don't want to go big and you want to stay easy, can't. But the only one that I can argue with you on is that you don't have an imager to figure out the size for you, because you actually don't need an imager to figure out the size for you. And that's the only thing that I can argue with you on. So let's talk about an LAA CT and how to analyze it. All you need is a TAVR CT, cut the legs off, and scan it with contrast. Any TAVR CT software or freeware, you can go ahead and use that. And then you need to practice on maybe 5 to 10 cases, and then you'll be able to get it. If you can do a TAVR analysis, you can do an LAA analysis. All you gotta do is find the circumflex artery, pivot to it, double oblique to it, get a maximal diameter, and you're set. The hardest part, though, is once you get this maximal diameter, and this patient is 23 millimeters, you have to go to Google and actually type in the Boston DFU for Watchman device. Once you open the PDF on this website given to you, you actually have to insert that number into the table on the chart here. And once you insert that, that's your device size that you will actually have to use. That's the most difficult part. If you don't have Wi-Fi connection, I can't help you there. But once you have that, you can actually do a CT arm planning. You can find the RAO caudal angulation, LAA caudal cranial angulation, and show your implanter what angle should they be using to put a device in, just to minimize some fluoroscopy time. And Dr. Sharma has shown the data already, but we can show that you're actually 3 millimeters larger by CT than TEE. Not so much larger, but more accurate. So the p-values are significant. But who cares about academics? Because we're all clinicians and we're here to help patients. So everything is purely academic. All manuscripts are purely academic until you experience the back pain that we experience. So in this patient, we put in 3 devices. We're attempted to, not my case, but we'll show it to you. The top one, the patient actually had a huge number leak. On the bottom left, they had a huge shoulder. And when we tried it a 3rd time, we completely almost popped out and we had a complete shoulder that didn't seal. So after an hour and 50 minutes, we were status post successful atrial septostomy. It was 3 devices that were 30 millimeters attempted. And the pre and the post cath did not have any significant difference. But we did have a lot of back pain. So 1 year later, when they came in, they had a CT. We did a correct lobe, correct guidance, and in 23 minutes, skin to skin, we got a 33 Watchman device in with an anterior curve, no complications. But then we always hear about ICE and getting rid of anesthesia and getting rid of the TEE probe so we can do procedures faster, like TAVR, which is actually planned by CT. So what do we do about that? Well, we demonstrated in our prospective trial that there is actually utility in actually doing CT planning, and there's actually benefit to it. But the most important part that we talk about is actually the transseptal crossing, because we assume that the fossa is located in the same position for every single patient's left atrium, where in fact the fossa, the right atrium, and the IVC all come off at different junctions for each significant patient. Patient on the left, you can see the IVC is actually coming off at 4 p.m. Patient on the right, the IVC is coming at 6 p.m. Such that if I were to draw this for you, on the left, I would need you to actually make acute angulation on your Baylis or whatever curvature you're going across to get into the left atrium. And on the right, in this patient, I can take an obtuse angulation on whatever curvature you want to get across the fossa. That does make or break a case. It actually will make or break the time in your case and your back. What does it look like on 3D print, just to show you a little bit better? On these 2 exact different patients with the SVC and IVC, notice how the patient on the right, the curvature of the SVC and IVC is actually obtuse, and it's actually completely angulated. So then when you come down with that wire, you're gonna fall off the aorta anterior curvature, and you're gonna drop off. So you need a curvature to get across. Whereas in the patient on the left, SVC, IVC is going 12 to 6, you don't need as much angulation to come across, and you're not gonna fall off that fossa. So it's gonna be easier for you to cross. That might be a change about 15 minutes in time. And what we showed in our prospective trial was that we could actually decrease the number of devices used, sheets, and also fluoroscopy angulations by knowing ahead by CT what we were going to do beyond device sizing, but also by catheter selection. So our divergence in the red and the blue was all because we had a better procedural planning, and we were able to save on average about 30 minutes in procedural time. That, compared to catheterization, lab time, and turnover, results in more procedures. Our efficacy, we had less complications. We actually had more procedural success, 98.2%, but we had some very large ones where we attempted that we couldn't get the device actually in. But then let's go back to ICE. In my mind right now, current 2019 two-dimensional ICE stands for I can't see. You're at 5.5 megahertz. But the other thing is, when you put the color on there, you can't actually see biplane imaging. You can't see 0, 45, 90, 135, the pass criteria. And really, we're all very stuck back in time. Fluoro is imaging, and it's way back to college days of cell phone, 25 cents a minute. CT is our iPhone 6. We really don't know what the LAA or the left atrium look like. We're still pretty archaic. So we can't be complacent, but you can also always advocate for ICE and think about how big of an ASD do you want to create. And we're really trying to prevent that stroke that we're going to all have in the future. And then we actually get into the barrier of surgical closure for PFO when we put too many catheters in green here on the far left across the fossa. But if you could see an ICE, the healthcare economics presents a slight problem right now in 2019. An ICE catheter is single use and costs $2,000. TE operators like myself are very cheap. We're only $95, in some institutions even $45. So the patients in the hospital right now, by the cost, actually lose. So the barriers are real in 2019, but the future of ICE is bright. Right now it's expensive and you have a lot of closures unless you stay in the RA. But there is a future for ICE and 3D ICE and 4D ICE and potentially mini TEE, but it's not available yet, potentially in 5 to 10 years. So in summary, CT is much more accurate. We already use it for TAVR. Why is the LAA not good enough? Adaptation of CT will actually allow our ICE technology to evolve so you can kick the TE operator out of the room. And if you have an easy button, why don't you use it? Up to you. Thank you.